Hello, I'm Dr. Anthony Wheeler, and I'm telling you everything that you need to know about pathology. Now, what are we looking at in this image? Duodenal atresia, right? Do you remember the quote-unquote buzzword for this? Is it double bubble sign? Right. We're going to be talking about that and much more in this presentation on small bowel pathology. This is covered in your book, Medical School Pathology and Step 1 Review. You can scan the QR code to get to the updated material. Now, this is a doozy. Make sure you're taking notes, okay? Because there's a lot of high-yield material here. We're going to be discussing the pathology of duodenal atresia, mecodiverticulum, volvulus, intussusception, small bowel infarction, lactose intolerance, celiac disease, tropical sprue, Sakapet, Whipple disease, abeta-lipoproteinemia, neuroendocrine tumors, right? You remember that salt and pepper? And acute appendicitis for all my folks going into emergency medicine. Let's start with duodenal atresia. Now, duodenal atresia is due to a congenital failure of the duodenum to canalize, okay? And it's associated with this imaging here, classically described as a double bubble sign, right? You see that? Imaging of duodenal atresia, again, will classically show a double bubble sign. And duodenal atresia is linked to Down syndrome. Do you remember the chromosomal abnormality with this? Trisomy 21, right? And since we're touching on Down syndrome, what leukemia are they at increased risk of developing? Acute myeloid leukemia, right? You remember that. I know you do. Now let's talk about some clinical features of duodenal atresia. We can have polyhydramnios, obviously the stomach distension and the duodenal loop that is blind, hence the double bubble sign, as well as bilious vomiting. Now here's another important pathology that you must know because it shows up all the time. Mecodiverticulum. Now a mecodiverticulum is when the gut's walls, 3 layers, are all out-pouched. So this is a true diverticulum. You can see that in this image here. Mecodiverticulum occurs because of the failure of the vitelline duct to involute. Now you remember the rule of 2s, right? And you know that the mecodiverticulum is associated with this, right? 2% of the population, 2% are symptomatic, 2 years old or younger, 2-to-1 male to female ratio, 2 feet proximal to that ileocecal valve, 2 inches long, and there's 2 types of mucosal lining, right? Rule of 2s for mecodiverticulum. And here we can see some imaging of a scan for mecodiverticulum. You see it lighting up there? And here we can see the angiography of a mecodiverticulum. And for the pathologists out there, or future pathologists, you're going to need to know this. GIST, for some reason, frequently show up in cases of mecodiverticulum, so be on the lookout for that. And GIST, by the way, means gastrointestinal stromal tumor. Now let's talk about volvulus, okay? Volvulus is twisting of the bowel along its mesentery, as we can see here in this plain x-ray. Volvulus, as you can imagine, due to the twisting, can lead to obstruction and disruption of the blood supply with infarction, right, causing mesenteric ischemia. Common locations of volvulus are the sigmoid colon and the cecum. For some reason, the sigmoid colon is more often affected in elderly patients, whereas it's the cecum affected most commonly in young adults. And here we have a CT scan from a patient with cecal volvulus. You can see it outlined with this yellow border. And here we have a surgery ongoing for a patient with volvulus that actually involved gangrene of the sigmoid colon. On CT scan of this small bowel volvulus, you can see two juxtaposed segments of narrowing, which is the spot of mesentery rotation. And the other one indicates strangulation. And here we have another CT scan from a person with volvulus. You see that there, outlined by the red circle? And volvulus occasionally can show up with a coffee bean sign. And here's an x-ray of a person with a small bowel volvulus. Plain radiographs can give us a lot of insights on the pathology that is present, as we can see here with this gastric volvulus case. Now let's get into another very important topic called intussusception, okay? What is intussusception? Well, you remember this. Intussusception is telescoping of the proximal portion of the bowel into the distal portion. This cartoon does a great job detailing the process of intussusception, right? You see that? With intussusception, the peristalsis actually pulls the telescoped segment forward, which causes blockage and interruption of the blood supply with infarction. You can see this on an ultrasound, and it's classically described as a target sign on the ultrasound, and that's characteristic for intussusception. Now, this isn't the first time we heard the buzzword target, right? We've seen that in hematology at some point. Speaking of which, if you have a red blood cell that has a quote-unquote target sign, what should be on your differential? Thalassemia, right? And I'm going to help you drill down a little bit even more. If it's macrocytic target sign, you should think of a specific pathology, perhaps with the liver, right? And if it's microcytic target sign, you should think of thalassemia, right? Okay, have those on your differentials, as well as the other hemoglobinopathies. Okay, now this is an important point. In children, lymphoid hyperplasia is the most common cause of intussusception. Intussusception typically occurs in the terminal ileum, resulting in intussusception into the cecum. The most prevalent cause of intussusception in adults is a tumor. Here we can see a CT scan from a patient with intussusception. Can you appreciate the target sign? And here we have small intestinal invagination shown on a CT scan. And here we have what intussusception looks like if you were actually doing the surgery or getting the initial imaging with A. Now let's talk about this, because this is intense. Small bowel infarction, okay? Small bowel damage from ischemia can be serious. Note this gray discoloration on this person's small bowel, indicating the infarction that's taken place. With a small bowel infarction, a transmural infarction presents with thrombosis or embolism of the superior mesenteric artery or thrombosis of the mesenteric vein. Mucosal infarction presents with marked hypotension. Features of small bowel infarction include abdominal pain, bloody diarrhea, and decreased bowel sounds. Here we can see a closed loop small bowel obstruction from a patient that had a history of appendectomy 8 years prior. Now it's important to note, and I want to point this out. Let me be clear that prior gastrointestinal surgeries increase the risks of small bowel infarction along with other conditions in which the adhesions can kind of hold and compress things, right? Because as you know, scar tissue develops after a surgery. In the abdominal region, they're known as adhesions. And these adhesions are fibrous connective tissue. And you could imagine when that heals, that fibrous connective tissue can cause things to be tight or squeezed. And that's why the risk of small bowel infarction is increased for patients with prior GI surgery, such as an appendectomy or a weight loss surgery, things of that nature. Now let's get into another common condition, lactose intolerance. Reduction in the lactase enzyme's activity, which is located at the brush boundary of enterocytes, may lead to lactose intolerance, right? Lactase typically breaks down lactose into glucose and galactose. Look at that. You can never escape biochemistry. By consuming milk products, the undigested lactose is osmotically active and causes stomach distension and diarrhea. Isn't that lovely? Lactose deficiency can be congenital or acquired. When it's congenital, it's typically a rare autosomal recessive disorder, or if it's acquired, that usually occurs in the late childhood. Temporary deficiency of lactose is visible after small bowel infection, right? Because lactase is highly susceptible to injury. Now, this is an important topic. You're going to see this for sure. Celiac disease. Celiac disease is an immune-mediated damage of small bowel villi because of gluten exposure, okay? And we can see that on immunofluorescence showing the staining of endomyosal antibodies, right? And more importantly, celiac disease is linked to HLA-DQ2 and HLA-DQ8, okay? All you future pathologists out there, this is what celiac disease looks like under the microscope. In a perfect world, you have a biopsy of the small bowel showing celiac disease manifested by the blunting of villi, crypt hyperplasia, and notable lymphocyte infiltration of the crypts. Wheat and other cereals containing the protein gluten, whose pathogenic component is gliadin, is responsible for celiac disease. And here, for you future gastroenterologists, you can see on endoscopy the duodenum from a person with celiac disease. Note this scalloping folds and the cracked mud appearance. With celiac disease, the tissue transglutaminase deamidates gliadin, and that has been absorbed, right? That's TTG. Antigen-presenting cells use MHC class 1 to present deaminated gliadin. Tissue injury is mediated by helper T lymphocytes. And this cartoon here to the right is a great classification scheme for the degree of celiac disease damage. Clinically, celiac disease may present with bloating, diarrhea, undernutrition, and small herpes-like vesicles that can be visible on the skin called dermatitis herpetiformis. So you future family medicine doctors, you future dermatologists, be on the lookout for this, because you guys are at the front lines picking up on the bloating, diarrhea, undernutrition, and those skin findings, right? Symptoms of celiac disease resolve typically with a gluten-free diet. Laboratory findings of celiac disease include IgA antibodies against the endomysium, tissue transglutaminase, and gliadin. And those labs are also present and helpful for diagnosing people with IgA deficiency. And note, there's a higher incidence of IgA deficiency that is visible in celiac disease. And to reiterate, the histology of celiac disease shows IgA deposition at the tips of the dermal papilla, and more importantly, and more to be tested, is the villi that are flattened, the crypts that are hyperplastic, and the intraepithelial lymphocytes, right? The jejunum and the ileum are less affected than the duodenum. The duodenum has the most obvious damage. Complications of celiac disease include small bowel carcinoma and T-cell lymphoma. Okay? And here we can see some imaging from the microscopic level that shows severe thrombocytosis and anemia that's associated with celiac disease, right? Anemia with celiac disease? Yes, right? You haven't forgot about anemia of chronic disease, have you? No, surely you haven't. Keep that on your differential when you're out there ordering whole blood cell differentials, etc. Now let's get into another important topic, which should be on the differential for celiac disease, which is tropical sprue. Now, tropical sprue is damage to the small bowel villi because of an unknown organism. This leads to malabsorption. Tropical sprue is comparable to celiac disease, but can only be seen for testing purposes in tropical areas such as the Caribbean, okay? Jamaica. Tropical sprue occurs after infectious diarrhea and is treated with antibiotics. The jejunum and ileum are most typically affected, and secondary vitamin B12 or folate insufficiency may result. The duodenum is less frequently affected by tropical sprue. Now here's another important condition. Whipple disease. You're definitely going to see this somewhere. Whipple disease is a systemic tissue injury characterized by Tropherma whipplei. Okay? Note on micrograph you can see abundant foamy macrophages in the lamina propria. The organisms that have partially been killed in Whipple's disease are found in macrophage lysosomes, which will be positive for PAS stain. PAS stands for periodic acid shift stain, and it typically looks pink if you have a good histology lab. The small bowel lamina propria is the classic site of involvement for Whipple's disease. And the macrophages actually compress the lacteals. Thus, the chylomicrons can be moved from the enterocytes to the lymphatics. So Whipple's disease is associated with fat malabsorption and steatorrhea. And guess what? The patient will likely poop out all their fat-soluble vitamins. Other usual sites of involvement of Whipple disease include the synovium of joints, causing arthritis, the cardiac valves, the central nervous system, and even the lymph nodes. And here we can see Whipple's disease on an H&E section. Note the foamy macrophages that are present in the lamina propria. It's important. Now let's talk about another important condition known as A-beta lipoproteinemia, right? You remember this. Apolipoproteins B48 and B100 deficiency are autosomal recessive conditions that cause A-beta lipoproteinemia, right? When you don't have those, it's inherited in an autosomal recessive pattern leading to A-beta lipoproteinemia, okay? The clinical features of A-beta lipoproteinemia include malabsorption due to the defective chylomicron formation, right? Because you need B48, as well as absent plasma VLDL and LDL, right? Because you need B100 for that. Here we can see histology from a patient with A-beta lipoproteinemia. Note the characteristic clear enterocytes due to the lipid accumulation. And here we can see acanthosis in a patient with A-beta lipoproteinemia. And here we can see some cartoon showcasing the absorption of cholesterol, etc. You can pause it and read this description if you like, but I'll leave that to you. Now, importantly, neuroendocrine tumor. Neuroendocrine tumor is also known as a carcinoid tumor, okay? And these can present in the small bowel, right, in the gastrointestinal tract. Neuroendocrine tumors are malignant proliferations of neuroendocrine cells. And do you remember what they stain for? Because we talked about this. Synaptophysin, right? And chromogranin, right? And CD56, right? They have that salt and pepper nuclei, right? You remember that? I know you do. I believe in you. Now, neuroendocrine tumors are positive for CD56, synaptophysin, and chromogranin. Never forget that. Especially, never forget synaptophysin, because at your level, that's the one that they usually ask about. Neuroendocrine tumors can occur anywhere in the gut, with the small bowel being the most common, typical place, right? Neuroendocrine tumors typically begin as small nodules that resemble a submucosal polyp. Like that we can see in the right. Doesn't it look just like some random polyp? But if you look closely, you will see abundance of neuroendocrine islands. And note, these neuroendocrine tumors typically and frequently secrete serotonin on exams. Serotonin is released into the bloodstream through the portal vein and converted to 5-HIYA by the liver monoxamine oxidase, MAO. Thus, the urine contains excretion of 5-HIAA, HIYA! And this serotonin can bypass, just jump, just skip, just transport past the liver metabolism when a carcinoid tumor spreads to the liver. And that will cause carcinoid syndrome and carcinoid heart disease. And that's caused by the serotonin being released into the hepatic vein and leaking into the systemic circulation via the hepatosystemic shunts. And you're going to get some symptoms with this, okay? So clinically, the symptoms of carcinoid syndrome include bronchitis, diarrhea, and skin flushing. And these symptoms of carcinoid syndrome can be brought on by eating cured meats like salami, pepperoni, right? Ah, mamma mia! Alcohol consumption, such as the red wine, and mental stress. Due to the presence of monoamine oxidase, which metabolizes serotonin in the lung, left-sided valvular lesions are not visible. Carcinoid syndrome is characterized by right-sided valvular fibrosis. This is increased collagen that causes tricuspid regurgitation and pulmonary valve stenosis. Now let's talk about a very important condition known as acute appendicitis. You future emergency room docs, you're going to see this a lot. Acute appendicitis is due to acute inflammation of the appendix. Acute appendicitis is the most prevalent cause of acute abdomen. Acute appendicitis is commonly associated with a fecalith or lymphoid hyperplasia that is obstructing the appendix. Now pay attention to this because this is very important. The clinical features of acute appendicitis include periumbilical pain, fever, nausea, pain that subsequently localizes to the right lower quadrant, right? McBurney point, and guarding and rebound tenderness are the symptoms of peritonitis, which occurs as a result of rupture of the appendix due to acute appendicitis. Complications of acute appendicitis include a periappendiceal abscess, and those are frequent. And with that, you've completed a very important presentation. So I'm very proud of you. Remember this because a lot of this will show up. You're going to see it in the near future. You're going to see it as a practicing physician. So keep up the good work. Let me know if you have any questions, any comments or concerns. Make sure you're subscribed. Make sure you're getting the updated material from the website. Keep up the good job, and I'll see you later.